Welcome to Ask the Educator, a podcast brought to you by Healthmark Industries. Are you a sterile processing technician or manager? Maybe you work in infection prevention or biomedical engineering. Whether you're a frontline tech, endoscopy tech, OR nurse, or surgical services administrator, you undoubtedly have influence in medical device processing at your facility. In each episode, we speak with experts from the Healthmark Clinical Affairs team, industry leaders, or special guests from the trenches to answer your questions and bring you relevant industry information, equipping you for excellence in medical device processing. My name is Kevin Anderson, and I will be your host. Now let's get started. Hey everyone, welcome to the Ask the Educator podcast. This is Kevin Anderson, your host. Joining me, as usual, I have Adam Okada from Healthmark, and one of the OGs of the podcast I have back is Stephen Kovach. Thank you, Steve, for joining us. This is going to be kind of a special episode. We have a couple returning guests with us from way back when we first started this thing, which is going to be really exciting. And we're going to tackle some great topics here about education and certification. So, Steve, if you wouldn't mind, just go ahead and introduce our guests for us, okay?
Yeah, thanks, Kevin. And I want to thank both you and Adam for allowing this topic to come about. For those who don't know, it'll be 20 years this June that New Jersey set the table for our profession to bring about certification and make it mandatory within a state. And I have always felt that there were three key people and others in New Jersey to bring this about. And I had hoped that now, 20 years later, we would have all 50 states, and we're not there. And so I want to introduce the people I have here, and then we're just going to open it up and talk about our future and go from there. One is, she's a dear friend of mine. I've known her for over 30 years, Miss Nancy Chobin. Another one is Mr. Tony Monaco, that I just think is the godfather of certification for us. Without Tony and without Nancy and without our friend Ian Cofield, who passed away, and I think the New Jersey chapters, I think Al Spath, who isn't on this, was a president at the time. They worked very hard, and I think we need to know the story and understand the path they took. Then I got my dear friend Don Gordon, who was president of ISHM in Long Island chapter, who was very instrumental in helping, along with many others, Mary Oliveira and a whole bunch of other people, and even Chuck Hughes, getting buses to go to New York and Albany to bring about certification. We're going to have an honest discussion about where we're at now and how do we get back on track. So thank you for joining us, and let's have a great discussion. And Kevin, it's up to you and Adam to lead us down this path.
Yeah, absolutely. So thanks for introducing everybody, Steve. And it's great to have everybody. So as you mentioned, New Jersey became the first state to require certification. Now it's 20 years ago, which is pretty mind blowing, actually, how much time has gone by already. But speaking on that, why is it that other states have not used the New Jersey blueprint to get certification passed through legislature? There's some other states that have gotten certification required, but also allowed to grandfather staff in. So it's one of those things where we got to think is it good for the profession? Is it better than what there currently is in so many other states where it isn't required? But, it's kind of a big question, but if we could maybe start with Tony and see what your thoughts are, Tony, and then kind of go on down the line with Nancy and Don as well.
I'd like to start that New Jersey is probably different than most states in the country, in that we have our own regulatory program. We have our own inspectors, we have our own licensing standards, and we enforce them. Before I even took over this program, I had 9 years of experience in inspecting acute care facilities. And then when I was asked to take over the program, I walked in, I had two strong central associations. I had two strong infection control organizations. I had a housekeeping association. I had a a facility management association that were all proactive with education. And to get all these outliers working together was important when I came in. And I think it's important that you understand what a regulation, how a regulation is adopted. First, a draft is developed, and then it's brought out. I brought it out to my inspectors because I had wonderful inspectors. I had a wonderful support team in the Division of Epidemiology and Healthcare Evaluations, and they helped as well. So we developed a first draft when we brought in the industry. We brought in the Hospital Association, the Ambulatory Association, Centrals Association. We had APIC in there, and we all worked together on developing the standards. Okay, and then once you develop the draft, that's not the end of it. Okay, I had to go within the department to the two different divisions, the Division of Epidemiology and the Division of Healthcare Facilities Inspection and Licensing. And I had to get those drafts past them. Once it was approved by them, it went to the Healthcare Advisory Board, which was a group of doctors and lawyers that were independent from the department that oversaw our regulations. And I had to sell it to them. Once I did that, I had to go to OAL, which is the Office of Administrative Law, and they had to go through it with a fine-tooth comb to make sure that each regulation met the standard of an enforceable document. So they made a clean change of it. Once they approved that, it went for public review. It went out for a 60-day public review to the public to submit comments to the department. Plus, there was a public hearing in which I actually ran that public hearing, and I was not allowed to speak during that public hearing. I was there just to listen. We had a court reporter that documented every word that was said in that public hearing. When I got back to my office, after the 60 days, I got the transcripts from the public meeting and all written comments received over that 60-day period. And I had to respond to each one of them and write a response to each one of them. And if I made one substantial change, I could make clarification changes, but if I made one substantial change in that document, it'd have to go back and go through the whole process again. All right. So once you get it approved, after the 60 days, and then once you get that finally approved, they give an active date to it. All right. So that gives me a little bit of time to work with my inspectors because the job is not done. You have to train your staff on every document that's in there. And then you have to do a dog and pony show across the state to get compliance to those standards. You want the industry to understand those standards. So that's a tremendous amount of work. It actually took me over 2.5 years from the beginning to the end.
Wow, Tony, I'm starting to understand why maybe it's been 20 years and not a whole lot of other states have joined this group of certification requirements. That's a very impressive workload.
It is. It is a workload, and most states don't do this because of that. And what they do is they may have licensing standards, they might have certificate of need. They're going to go out and do complaints in the industry. They're going to review new plans for new construction and new facilities, that type of thing. But as far as the regulatory component, they're going out to the accreditation agencies. They give that responsibility of the accreditation agencies. So to be honest with you, a lot of state health departments do not have, I look at the expertise. I had Nancy Chobin with me. I had so many good central supply directors and technicians in my state that were very proactive on this issue. It made my job a lot easier, even though it is a tough path to go. But if the state doesn't have that, if they don't have strong central associations to sell it to the regulatory officials, it's going to be a hard a hard task to accomplish.
Can I ask both you and Nancy real quick? I know Don's going to come in later on what happened in New York. How did you get the backing of like senators or representatives or did you need somebody to sponsor the bill, or because the path that you
No,
took, you didn't need them to sponsor it, right?
we didn't need it because the legislature gave us the authority to promulgate regulations. Okay,
Ah,
we didn't have to go to the legislature for it. We had the authority to do it right from the get-go.
really?
In New York, you talk to Don about it. New York had state standards. In fact, they had an inspection program when I started many, many years ago. But they went the accreditation route as well and got rid of their inspection group. So what they had in New York was a group in the state health department that really didn't know central supply.
Okay. I want to get to New York in a little bit, Don. I want to bring Nancy in because you and Tony and the others, you made sure you gave people X amount of years. I forget what it was to get certification, or you couldn't practice. How did you go about selling that, Nancy? That there were people who maybe lost their jobs if they didn't get it. I can't remember. Was it 3 years or 5 years?
Five.
How many?
5 years.
That's a lot of time for people to get
Yeah.
it. Could you comment on that, Nancy?
Yeah, I believe that was something that the New Jersey Hospital Association was concerned. And correct me if I'm wrong, Tony, they supported the bill, but they were concerned about a mass exodus of sterile processing people unless there was sufficient time to give people to not only study, but as you know, some people are not good test takers. So what if they fail the first time around? Are they going to lose their job right away? So the 5 years was what they came up with. And we just agreed with it as an organization and as a group working on this because we felt it was that important. And I think people have to recognize when they're going to do something like this, you have to have the infrastructure to do it. And this was one of our concerns. Did we have enough instructors? Because you can learn this self-study, but a lot of these people, this was a lot of new information for them. And to have it face to face, to have an instructor who could teach it and demonstrate and do things like that which was important. So we made sure that we had that between the two organizations, Isherman's and the New Jersey Healthcare Central Service Group, that we had enough programs. I remember Tammy Maresca and I teaching classes with 90 people at Kane University because, people wanted to make sure they had their education so they could sit for the exam. So I think that was a win-win. But I'll tell you, in my own system, we had people waited until the last minute. They took the exam, they failed, and they lost their job.
Wow.
Now, in our system, they were offered another job, but it might have been in another department at less pay.
Wow.
I had, in all the years, I only had 2 people that were brought to my attention by central directors, and those 2 people had language problems. And the central directors were very supportive of these 2 staff, and in different hospitals. And they had a skill set, but they didn't have the language to pass the exams. That's what was put to me. And they asked me for a waiver. And I couldn't give a waiver. I didn't have the authority to waive a state standard. So as Nancy said, those employees were transferred to different, one was transferred to transport, which didn't involve processing.
Right. But we went through we started 2 years ahead of the deadline, sending letters to everybody in the department, sending them when it got closer to the date, 6 months before, they were sent a registered letter. They were given another letter in the department, hand delivered to them by the manager, 3 months before, 2 months before. And these people just decided that, for one reason or another, I'm just going to wait till the end. And there was no language barrier here. It was just procrastination. And unfortunately, it came back to bite them. We lost 6 people in our system.
So, Don, I'm going to say something here to bring you in. And later on, Adam, I've talked to him earlier. He knows a lot what happened in California, why it didn't happen. But, I do believe that certification should be required regardless if you've been in 1 day or 20 years. I think the basic certification sends a message that you have a general understanding what you need to do in the department. I think it projects a level of professional ability for me, and it helps formalize your knowledge. I'm not saying that somebody who's not certified does not know the basics. And in fact, I know many staff who are not certified who know more than people who do get certification, but just grandfathering in to me has been amazing. And Don, why don't you share a little of what went on in New York? Because Tony has really told us that you really have to know your state and how they function and to work with so many different people. And because they had the law behind it, they didn't have to go out and get somebody to sponsor bills. And that's what I think you had to do in New York, correct?
Exactly. You're correct. I just want to give a brief history on how we started. The first time in the Long Island Association was the one that really spearheaded the mandatory certification in New York. And what happened was we were at an initial meeting in St. Louis where Tony spoke. We were all inspired by him. We became friends. Ann Cofield introduced us to Tony. We stayed with him during St. Louis to make him feel comfortable and everything. And we were so inspired by what Tony did that we wanted to do it in New York. Back then, there were two national associations, and there were the local associations for upstate, which was from the American Society, and the downstate New York and Long Island were from Isham. So what we had to do is we had to try to get everyone together on the same wavelength. So the day before 9/11, I remember we scheduled a meeting. There was a conference up in near Binghamton that we went to, and all the leaders in those associations in New York, I think there were 5 then, got together the day before 9/11. I'll never forget it. And we all said that we were going to go ahead. We were all inspired by having mandatory certification. We thought we needed it. And we decided to form a New York State Association, even though they were made up of 2 different groups, one from the American and one from Isham. We got together and we formed our own New York State Association. Chuck Hughes, like you mentioned before, sponsored all the expenses for the meeting and helped arrange a meeting in Albany in which we got together and we were going to put through bylaws for the association. I thought it was going to take a long time, but we got it done. We wrote the bylaws and we became a New York association. Then we had to develop a way of trying to get it. We didn't have anyone in the State Board of Health, so we knew we had to go through the legislature.
So you didn't have a Tony?
We didn't have a Tony.
You didn't have a Tony. Okay.
That was the main thing, and that's why it took us 10 years before we actually got mandatory certification in New York. And we would go up every year to Albany. We would take in the beginning local assemblymen and state senators that we knew and set up meetings and hope to get their interest. We'll make a long story short. One of the board of directors up in Syracuse, I think it was the Syracuse area, that was on our board of directors in New York State, her brother became a state senator, and he sponsored a bill. But the big change happened when Isham supported us with hiring a lawyer to work with us on getting these bills through. I can't remember her name now. With her help, we started talking to this gentleman, the state senator, and others, and we kept on going up there every year. We would go up and visit and talk to people.
And didn't Tony come up one year with you guys on a bus or something,
I'm
Tony?
pretty sure he did. Tony,
Yes,
you
I
did.
did.
Didn't you, Tony?
Yes, I did.
And you were with
Yep.
technicians in the room or whatever, because Don, what seems to be going on is New Jersey blueprint couldn't be followed in New York, so you tried to find another way, and that other way was you had to compromise and put in this grandfather clause, correct?
Exactly. The compromise was because we had we had the AORN nurses and the unions that were opposed to it, or I wouldn't say opposed, but were cautious about us doing this. And because of that, we had to make them part of the getting them on board in order to get this legislation through. The unions were very, very powerful in New York. And the reason for that is most of the people working in sterile processing then had very poor reading skills. They actually had people who would come into the hospital, especially in the New York City and Long Island area, and do a reading course for the staff so they could develop reading skills so they could actually read the test.
Mm.
They had the skills to put instruments and trays together and the knowledge of that, but they couldn't pass a test because they couldn't read. They couldn't read questions. They had like a third or fourth degree reading level. And so,
I mean, that is a whole different issue too.
well,
Wow.
that was an issue then.
Yeah. Yeah.
That's why it took so long for us to get it through. And that was another reason for the grandfather clause, that most of us didn't want the grandfather clause. But when we saw that we would probably lose half the profession in the New York City area because they couldn't read and they couldn't take a test, we had to give them time to train and learn the test and learn, how to take a test. So it was something that we had to give in to the unions and also the AORN Association.
But anybody after that date has to be certified. They were just grandfathered in.
It was a 10-year grandfather, and I know you were certainly opposed to it. You and I had many discussions on it, but
yes, we did.
We had no choice. We were looking more towards the future of sterile processing instead of the immediate. We didn't want to shoot ourselves in the foot, so we were kind of forced to do that.
I want to go quickly to Adam and then bring this back to bring Nancy and Tony in. Adam, would you mind telling us a synopsis of what you were involved in California and then how it failed or why it failed? Do you mind doing that for a few minutes there, Adam? Because we're going to then have 3 different things that took place and then talk about how do we get people back onto maybe the New Jersey blueprint, because I think that still is the best blueprint. Adam, would you mind?
Yeah, so I wasn't really a part of the group that was doing the certification at the state level, but I did write letters to the congressman. I was told by the association and ISHA, which is now HSPA, to send some letters to certain people. So that's what I did. And then afterwards, when I kind of followed up and I was asking what happened at the hearing, because that was why we were sending those letters. We wanted them to vote yes on that bill. We were told that there was a doctor group, and I'm not going to mention the name of the group here, but there was a doctor group who had lobbied and paid millions of dollars to a lot of the people that were voting to vote it down because they didn't want to pay their technicians $1 or $2 more per hour for certification. So they spent millions to vote this down, which would have been way more expensive than just paying their guys $1 or $2 more.
I don't know if people can see this if we're doing the video, but you just got both Nancy and Tony moving in their seats. So that is very interesting. So let's go to you, Nancy, and then see if Kevin has some questions. But Nancy, how do we really get these other states? I think, again, what you and Tony and everybody else, and you're the 2 sort of representing here, how do we address this to get other states to not grandfather, but be inclusive and get people to push towards certification? We've got a couple examples from Don and what little Adam knows. How do we go about this? What do you think we need to do?
You need people who are passionate about it, who really believe in it and are willing to put the work into it. I won't mention the state, but a colleague of mine, their state tried very hard to get certification. And they were told, well, if you hire a lobbyist, we can help you get it through the legislator. Well, the lobbyist wanted a minimum of $30,000 and couldn't even guarantee anything. Where are these groups supposed to get that kind of money?
Mm-hmm.
You've got to find someone in whatever your rule of thumb is, if you have a legislature or what have you, you have to do your homework and find out where to start. You have to have someone who's going to have the clout to support this agenda. Then you have to provide the expertise why it's needed. I know when I was looking at certification here in New Jersey and we met with the Center for Professional Achievement, when I went to them and told them what we were doing, you know what they said? Why are you just looking for certification? You people should be licensed.
Oh, let's not go license certification, but wow.
But I'm saying, they got it. So, you've got to present the information. I just have trouble understanding why anybody wouldn't consider this the utmost in patient safety, especially today when we have instruments that defy cleaning in many cases. But you've got to have the people who are passionate. You've got to have the people who are willing to put the work in. And then you've got to have a support system outside of sterile processing who's going to help you achieve your agenda.
Yeah.
And each state is going to be different.
And then I do not want to downplay the other states that have got certification. They figured it out and they felt it was important for their state. And I have to commend them. But if there's only 5 or 6 states, we've got 40, 45 more that we need to help them figure out what to do. And Tony, you've heard some examples. What advice do you give to people to really start it back up? Because we're 20 years and we should have done a lot more in what I feel. What are your thoughts real quick?
I think if you go the legislative route, I'll never see certification become a national standard in the United States. I'll be dead and buried. Or if I'm still alive, I won't even know who you guys are, to be honest with you. So I don't think I think we have to really examine what we're doing and maybe take a different approach. Maybe it has to come within in the central service groups themselves, on the local level and on the national level. We need to accept certification and mandate it within our hospitals.
And we see that.
I think that's the fastest route.
I really agree with both what Tony is saying and what Nancy is saying. The problem is, and Nancy identified it, I don't see the passion in the profession like I saw years ago. It's not there.
Yeah.
It's not there on the local level. I don't think it's even there on the national level. I think that the passion is gone. They don't have the leaders that they had then that were really gung-ho about their profession. I mean, it's just terrible that so many chapters have closed down. So many associations, local associations are gone. The Long Island Association is now ending its long history in the field because we can't get anyone to take over from the people who started it and ran the association for many years. All of us are retired now and we're trying to keep it afloat, and we can't do it. No matter how we try to recruit people, no one is interested in giving up their personal time for the profession. And that's where the problem lies. And in some instances, I blame the National Association for not making this one of their big priorities. People who are now leaders there, I feel, have deserted that cause.
I want to bring something in, and I want Kevin and Adam, and then Nancy, it is going to spark something in you. We go into a lot of hospitals, just like you and Tony. I know you're still doing some consulting. It seems to me hospitals are using either career ladders or they're requiring certification to hire people regardless. Kevin and Adam, you've been in a lot of hospitals, and we do these audits and we look at stuff. Do you see that's the route that hospitals are now saying you've got to be certified? What are your thoughts real quick?
That's generally what I'm seeing across the board, is that the hospitals themselves have seen the value in having certified technicians, and then they just put it into their hospital policy and HR policies that, hey, we value certification here, and the expectation is you can come in and you can start working, but within a year, some of them I've heard even within 6 months are requiring certification. Now, that's probably common, I would say, in the majority of the metropolitan areas and things like that. I can't say that that's probably the case for the rural areas, the places that are maybe a little bit more resource strapped, which makes sense. And it kind of goes back to Don's point with the state of New York. I mean, they had some unique circumstances there, and I happen to agree with you, Steve. Like, I mean, I don't like the grandfather thing, but it also allowed for them to actually make a meaningful change there in their state. So I understand both sides of that, and I think that that's kind of what the hospitals are up against too. They need to push for quality, require certification is where they're kind of putting it. And that's in lieu of having state legislature, which is a good thing. But, eventually it'd be nice to get to where do we go from here, which is the idea with this podcast. And there is some ideas, that I've shared on this podcast and in other platforms, but I won't get to that yet because I want to hear from other people too. But I think that is a very common way for hospitals to address it. I know that was how it was in my facility. I know some places have even more sophisticated career ladders, which is phenomenal. I wish that was more the norm at this point. There should be some credit for people who get those multiple certifications. There should be all of these other options going on, given the growth of this industry and the changes and the evolution that have taken place over the last 20 years. Unfortunately, that's not necessarily common, but at least the requirement for certification, that's what I've been seeing. How about you, Adam?
Well, I think this conversation is amazing. So I hate to cut it off right here, but we are at time.
Oh.
So what we're going to do is we're going to have part 1 of this, and we're going to come back for a part 2. So it's great conversation. We're going to keep it going in part 2. So come back for that.
Can I wait, before you shut this off, Adam?
Okay.
Go ahead, Don.
I wanted to say that career ladder program worked for me at Hospital for Special Surgery. I developed one where, and the good thing for me is I didn't have a union. So the unions can sometimes hurt you and sometimes help you. I didn't have a union, so I got it through Human Resources. And for every certification, they received a $500 increase in their pay. So if they had 3 certifications, they got that. I also had levels. And if you had a leadership certification, you were able to become a lead tech or a supervisor. Without that, you wouldn't be able to get that. So that was a good point about the career ladder program. That works in most hospitals.
Thank you guys for tuning in. Thank you to Nancy Chobin, Tony Monaco, Don Gordon, and we'll be back for part 2. So stay tuned for that.
All opinions expressed on this show are those of the presenters. Before using any medical device, it is important to review the device manufacturer's instructions for use.